In this recording, we're going to continue our study of Module G, Neuromuscular Alterations in Nursing 202. In this recording, we're going to focus on Parkinson's, Bell's palsy, trigeminal neuralgia, and Guillain-Barré syndrome. Our first condition is Parkinson's disease. Parkinson's disease is a chronic, progressive disorder characterized by tremors, rigidity, slowness of movement, and postural instability. It's uncommon in people younger than 40, and the incidence increases after age 60. The causes of Parkinson are not known, but genetics, age, and environment are all involved in Parkinson's. The disorder is caused by a loss of neurons producing dopamine. And this is a monoamine neurotransmitter necessary for movement. And so we're going to see problems with movement. The cardinal features again listed are tremor at rest, rigidity, bradykinesia or slowness in movement, flexed posture of neck, trunk, and limbs, loss of postural reflexes, and freezing movement. And so this is just a picture of what someone with Parkinson's might look like. Their gait is usually shuffling in nature, and they're kind of humped over there, stooped posture. And this is just another picture of some of the characteristics of Parkinson's disease. We also see the manifestations listed on this slide, particularly as the condition progresses. With skin problems, their skin breakdown, they typically have an intolerance to heat and low blood pressure with standing. As the condition progresses, we see dementia and depression particularly. And they may also have some problems with constipation and anxiety. There are a variety of drugs used to treat Parkinson's. The most common ones are the dopaminergics and the dopamine agonist. We also see MAO inhibitors, anticholinergics, and catecholamine O-methyltransferases. Surgery is another option for treatment with Parkinson's. So with the first drug listed, levodopa, it's a precursor to dopamine, and it's used to decrease tremors, rigidity, and postural instability. Levodopa is able to cross the blood-brain barrier so the neurons can convert it to dopamine. It's usually given in combination with carbidopa, levodopa, or Sinemet to decrease the breakdown of levodopa, allowing more levodopa to reach the brain and decrease the nausea, vomiting, and orthostatic hypotension caused by levodopa. As the disease progresses, the dosage may need to be increased because the effect wears off before the next dose is due. There are some dietary issues with levodopa because protein may decrease the effect on motor function. So the medication should be given 30 minutes before or 1 hour after eating, and high protein meals should be avoided. Adverse reactions associated with levodopa include dry mouth, drowsiness, constipation, anxiety, and it can cause orthostatic hypotension, confusion, nausea, vomiting, and anorexia. With the dopamine receptor agonist, and listed here are those. They may be used to delay the need for levodopa or as a supplement in the later stages of the disease. They're started low and slowly increased in dosage and may take several weeks to months to reach maximum benefits. Adverse reactions to these drugs include sleep attacks, and these can occur without any warning, hallucinations, postural hypotension, and increased risk of compulsive behaviors including hypersexuality, compulsive gambling, and compulsive overeating. The MAO inhibitors, these help prevent breakdown of both naturally occurring dopamine and dopamine formed by levodopa. This is accomplished by inhibiting the activity of the enzyme monoamine oxidase, which metabolizes dopamine in the brain. The adverse reactions to these drugs include confusion, headache, hallucinations, and dizziness. It's important to remember these medicines can't be used with other antidepressants. They can't be administered with Cipro, St. John's wort, ginseng, or methadone. And there are some dietary precautions with MAO inhibitors that you all have already learned about. Foods high in tyramine, such as aged cheese, cured meats, and other foods. The catechol O-methyltransferases block an enzyme that breaks down levodopa. This prolongs the effect of levodopa. These medicines are used in patients with end of dosing weaning off. And the anticholinergics are used in younger patients to help control the tremors. There are some other drugs, and I'm not going to get into those for this condition. We see sometimes electrodes implanted in the brain and connected to a pulse generator, and these can be programmed externally to decrease the dyskinesias and help decrease tremors, gait problems, and slowed movements. Evidence is showing that this procedure will work well for 3 to 5 years. And there are risks associated with these types of surgeries, such as confusion, bleeding, and infection. And brain stimulation is only used in patients with moderate to severe Parkinson's because of the risks related to the procedure. The prognosis of Parkinson's, it's not a fatal disease in itself, but the complications oftentimes lead to death, such as choking, pneumonia, infections, and falls. They're very common. And at the end of life, the anti-Parkinson's drugs are not as effective. Care centers on safety because they are at risk for falling, particularly, and mobility and immobility issues. They progressively may have problems with communication, sleeping, swallowing, and nutrition, and elimination and self-care. So our care is focused on these aspects relative to where the patient is in their condition. The next condition is Bell's palsy. It's a condition that affects motor aspects of the facial nerve or the seventh cranial nerve. It's the most common type of condition with peripheral facial paralysis. It affects men and women, but it's most common in people ages 20 to 40. And it results in unilateral paralysis of the facial muscles of expression. Oftentimes this condition is confused with stroke. There's no evidence of any type of cause, and the facial paralysis is the most common symptom. We may see central facial palsy in the upper motor neuron that results in paralysis. The client cannot voluntarily show their teeth on the paralyzed side. We see upward movement of the eyeball on closing and drooping of the mouth and a slight lag in closing the eye. The person can't whistle or wrinkle their forehead, and eating is the most concerning symptom because there's the risk of swallowing and aspiration. And it may take weeks to months to resolve. So this is basically how Bell's palsy looks. And you can see it may be the cause may be a reaction to herpes vesicicles in or around the ear. Treatment involves corticosteroids, antivirals, and we see usually 85% full recovery in 6 months. So the facial nerve movement's what's involved. There's no cure. Analgesics may be given for discomfort from the herpetic lesions. Again, corticosteroids to reduce edema. The Zovirax is for the herpes specifically. Physiotherapy, moist heat, massage, and stimulation of the facial nerve may be helpful. And sometimes artificial tears are necessary and sunglasses. With the neurological assessment, with the Bell's palsy, you want to just get a good history because you're trying to rule out stroke. Your physical exam should include assessing their level of consciousness. There should not be any problems with level of consciousness with this condition, and checking the motor function. And so, the only involvement is the face, and so you shouldn't have any weakness on either side with the limbs. You want to check the pupillary function and eye movement, and obviously check their respiratory condition because you're concerned about aspirations and their vital signs. And so the big thing you want to do is reassure the patient that they've not had a stroke and that most patients recover within a few weeks. If permanent paralysis occurs, then surgery can be performed where they do anastomosis of the peripheral end of the facial nerve, and so there's some good results with that procedure. The next condition we have is trigeminal neuralgia. It's a chronic irritation of the fifth cranial nerve. It has 3 divisions, the trigeminal nerve does, and it may occur in any one or more of these divisions. So it can occur in the ophthalmic, maxillary, or mandibular areas. And so you can see here a distribution of the trigeminal nerve in its 3 divisions. It's characterized by intermittent episodes of intense pain with a sudden onset. Its pain is rarely relieved by analgesics. And tactile stimulation such as touch and facial hygiene and talking can trigger an attack of this. It's more prevalent in the maxillary and mandibular distributions on the right side of the face. And we don't usually see it on both sides. None of the current diagnostic tests actually identify this condition. We may see CAT scans, MRIs, and angiographies done to rule out a lesion. Diagnosis is made based on a good history and attention to what's triggering the pain and the site of the pain. This is just a mnemonic that you can use to study the nerves and that sort of thing. So I just wanted to share that with you. You want to get a good history if you suspect this condition, and find out what's triggering it. Find out about dental hygiene and nutrition intake, because sometimes they want to avoid those things if they're experiencing this, and that's not good necessarily. Medications include anticonvulsants listed here. They dampen the reactivity of the neurons with this nerve. In some clients, these medicines are all the treatment that's needed. If they're on these medicines, we need to monitor their liver enzymes, because they can cause liver damage, and they need to be not used with alcohol. So education about that's important. But the priority with these is managing the pain. It can be quite disturbing to the patient. Another medication that can be used is the baclofen. It's an antispasmodic that can be used alone or in conjunction with the anticonvulsants. And narcotics in this condition are not particularly effective. We want to help the patient use and improve pain control, whatever we come up with that works for that patient, and provide a lot of emotional support, because this can wear on and really be irritating to the patient as you're studying. A couple of procedures used for the trigeminal neuralgia include the percutaneous stereotactic rhizotomy. And more invasive is the craniotomy with macrovascular decompression. Both of these conditions are not used, though, unless the medications are not effective. The percutaneous stereotactic rhizotomy is performed in the ambulatory setting, and the surgeon passes a hollow needle through the inside of the patient's cheek into the trigeminal nerve. A heating current is used and goes through the needle to destroy some of the fibers. The entire nerve is not destroyed. So this helps with long-term pain relief and tolerance by older adults, absent of facial paralysis and preservation of the sensation of touch. The affected site is permanently insensitive to pain. After this procedure, ice should be applied to the operative cheek and jaw for 3 to 4 hours, and a focused cranial nerve assessment should be used to assess whether other nerves have been damaged with the procedure. The more extensive procedure is the craniotomy with the microvascular decompression. So we're talking about brain surgery, basically. In some patients, a small artery compresses the trigeminal nerve as it enters the pons, and surgical relocation of this artery, or microvascular decompression, may relieve the pain. There's a lot of complications, obviously, with this type of surgery that we have to be on guard for, including aseptic meningitis, cerebral spinal fluid leak, ataxia, hearing loss on the same side, and facial nerve damage. It's quite rare, though, that you would be taking care of a patient like this in the general setting. This is more for intensive care nurses as far as that. I look forward to seeing you in class. Our next alteration is Guillain-Barré syndrome. It's an autoimmune disorder where the myelin sheath is destroyed. There's inflammation, which causes problems with the brain receiving fewer sensory signals. These patients can't feel texture, heat, and pain. They experience muscle weakness beginning in the legs that spread upward to the arms and upper body. The precise cause is unknown. Most report a viral infection 1 to 3 weeks before the onset of clinical manifestations, usually involving the upper respiratory tract. So there are some triggers that they suspect may be a cause, including viral infections, bacterial infections, certain vaccines, lymphoma, surgery, and trauma. The condition affects the motor and sensory pathways, as well as the autonomic nervous system functions of the cranial nerves. The degree of damage impacts the degree of neurologic dysfunction. Symptoms include motor weakness, usually beginning in the legs, paresthesis and other sensory changes, cranial nerve dysfunction, especially oculomotor, facial, glossopharyngeal, vagal, spinal accessory, and hypoglossal problems. Usually they'll report an abrupt onset of lower extremity weakness that progresses to flaccidity and ascends over a period of hours to days. Motor loss is usually symmetrical, bilateral, and ascending. In most severe cases, we see complete flaccidity of all peripheral nerves, including spinal and cranial nerves. Frequent assessment of the respiratory system is essential. The most common cause of death is respiratory arrest. So maintaining an airway is important. As the disease progresses, respiratory effort weakens and intubation is necessary, and mechanical ventilation. They may also develop, as the condition progresses, complications related to immobility. Physical and occupational rehab is important to try to maintain some functioning. There's no curative treatment, though, for this condition. The disease must run its course, and it advances over 1 to 3 weeks and then remains at a plateau for 2 to 4 weeks. The plateau stage is followed by descending paralysis and then a return to normal or near normal function. So we've got to try to maintain the muscles, with the physical and occupational rehab, maintain nutrition, but we also want to make sure they have an advance directive, because there is a possibility of respiratory arrest. So our focus is on maintaining and surveillance for complications, initiating rehab, facilitating support. Emotional support is important as well. This immobility, again, can last for several months. Treatment may involve plasmapheresis and IVIG. I encourage you to read about both of those types of treatment. Plasmapheresis involves, actually, is similar to dialysis, where the patient is hooked up to a machine that looks like a dialysis machine, and they actually perform this procedure in the dialysis department at Huntsville Hospital, and actually go through and take out, components that are present there in the blood. Respiratory therapy, obviously, if respiratory arrest is the main problem, you're going to be providing respiratory therapy. Treatment to prevent blood clots is also important because of the immobility. So the patient may be put on Lovenox or low-dose aspirin and be prescribed sequential compression devices and TED hose. Pain meds that are often given are nonsteroidal anti-inflammatory drugs and acetaminophen. This concludes this recording. We will have a couple more recordings on this learning module. Thanks very much.